Thank you very much, everyone, for waiting. Dr. Urvish Patel is here, and I would like to welcome my moderators to introduce him, although he doesn't need an introduction. But yes, Esha, over to you.
Hello, Dr. Mansuri. So we welcome you all to next session, and I have the pleasure of introducing our next speaker, Dr. Urvish Patel. Dr. Patel holds a Doctor of Medicine and a Master's of Public Health and Biostatistics. His areas of interest include neurology, internal medicine, epidemiology, biostatistics, global burden of disease, translational medicine, and clinical research education. He has received training in the outcome, survival, predictive, cost-effectiveness analysis, and management of clinical trials. He has developed expertise in systemic review articles and meta-analysis, analyzing clinical data from hospital registries and national databases such as NIS, NRD, NSQIP, NHANES, YRBS, GWTG, etc., and grant writing, budgeting, and submission. He has completed over 150 projects and has over 2,000 independent citations. Under his lead authorship, many of the projects have been awarded the prestigious AHA Junior Investigator Award, AHA Stroke Minority Travel Grant, AHA Paul Dudley White International Scholar Award, ANA Travel Awards, WCN Travel Award, ISMMS Graduate School Travel Award, Young Investigator Award in Clinical Cardiology, and has been recognized by media such as Practice Update, Consultant 360, and Medscape. So with that introduction, I welcome Dr. Urvish Patel to talk on the topic approach to meta-analysis and the importance of original research in the residency application. Dr. Patel.
Thank you so much, Dr. Esha Vaish and Dr. Zeeshan Mansuri for giving me such a wonderful platform. And thank you, Dr. Garima and the core team of the Humans of USMLE to provide us this great opportunity to engage with multiple researchers and share their insight about clinical research and helpfulness of clinical research in the journey of USMLE. I would not take much time for the other importance of clinical research in the journey of USMLE. I think the previous speakers made themselves very clear that how important it is to work on your clinical research and how can you basically as the complete journey of clinical research and how you can utilize that for the USMLE and also for the candidate who are not applying for USMLE. For them also it's a various helpfulness. Now, I have chosen this specific topic of fundamentals of systematic review and meta-analysis for a few reasons. Number one, usually when people are presenting the case report or observational studies or clinical trials and so many different type of original research, when we use the original research word, then now I think you're very clear about original research means something that is a new concept. That means something that is a fresh outcome or fresh result that you can able to present in the conference and publish in the original research category. But people have asked several questions that can we, without IRB publish the case report, can we proceed with the national data or can we proceed with the other type of original research, and that will be helpful to us in the USMLE journey. And some people said yes, some people said no, some people said depend on the program, depend on the case report, and so many more things. So when there is the dilemma, of course, there are always loophole for us to make something in a way that we can design in a way so that without IRB, without hospital, without affiliation within United States, you can proceed with the original research. But some of the article or some of the type of the articles are very special. For example, systematic review and meta-analysis, even though it comes in the category of original research, even though it produced the highest quality of the evidence in the top of the pyramid, we'll discuss about the pyramid too, still it is considered as original research. You do not require IRB, number one. You do not require affiliation within United States, number two. You do not require a specific mentor like cardiologist, hemonc, or GI, or someone who can help you. If you have a particular skill, then you do not require those things. You can sit in your home, You work over weekend, it's exactly like a literature review, so that which does not require any affiliation, but that's not original research. We will discuss about the importance of original versus non-original research, why both are important, okay, and why one is more important than other as well, and in which quantity we should have everything in your CV. So most important thing is the systematic review and meta-analysis considered as original research. You can do it over weekend from your room without having any affiliation in anywhere, no IRB required, and that is the only reason it is very fast to complete and publish. Like literally in 2 hours of span, if the data is collected well, then we can publish fundamentals. So basically the whole article, or I can say the analysis of the whole article for the conference within 3 to 4 hours of the timing. So that's the most important thing which I want to make sure emphasize more about that. So with that, we can start beginning our systematic review and meta-analysis with the data collection strategies. So before I quickly jump into the systematic review and meta-analysis, I would like to share with you some of the other important type of the reviews, which is requiring some time specific method, which means search strategy, which means aims and objective, which means synthesis of evidence, which means maybe or may not be analysis, but that can consider under the review subheading of review, and still it's important to important if we can convert that into the original research and if we can publish as an original research category. So I'll not go into much detail, but still we'll just quickly go through some of the labels of the review article. First one is a critical review, and the critical review, the name is given to that review article as a critical review because when you are going to work on such topic, when you are going to evaluate that particular concept using population, intervention, comparison, and outcome with the PICO strategy, you are going to evaluate it thoroughly, and then you are going to make sure you are going to make the hypothesis or modeling out of it. And though you do not require maybe analysis, but still it's critical to change the guideline. Many times what people are doing it that they are having, let's say, 3 to 4 original study and 3 to 4 meta-analysis, sometimes clinical trials and stuff. Then American Academy of Neurology or American Heart Association or American Psychiatry Association sit together, get all the evidence, write a proper review on that with the full description and citation of those paper, and they publish it in order to make the new guideline. In a fancy term, we use it in a practice update. That's like a U word for physician, and all practice update is having sorry, up to date, not the practice update. Practice update is the newsletter for the physician, but up to date is the what I can say, the application where all this guideline published. So sometimes people use the word as a critical review. Now, second one is a literature review. We had a thorough lecture on literature review. Just you require abstract, introduction, discussion, boom, you're done. So that's a literature review. You know it very well. Now, mapping review or systematic map, it's okay. It's not a big deal right now, because sometimes when you are going with the Bill Gates Foundation or WHO and CDC, then they map some of the areas, they do the analysis, they put the projection of the things. So that is out of the scope right now. We don't want to take much time on the mapping reviews. Meta-analysis. So when we discuss specifically meta-analysis, so I'm just telling you that you all are aware with the literature review. Think about in this literature review, I'm adding systematic search. I'm adding systematic search using PICO. That will make it as a systematic review. Okay, I'm keeping it in the same category, but now I'm going to add in that two. I'm adding one more thing: analysis. When I'm going to do analysis could be of few types. Analysis will be of the categorical data. What is the meaning of categorical data? Means that occurred, that did not occur. Mortality is higher, mortality is lower. Or let's say disability is higher or disability is lower. Someone won gold medal, bronze medal, silver medal. So it's called categorical. Then we call it is equal to meta-analysis. If we are doing continuous data analysis, that what is the pooled prevalence of, let's say, myocardial infarction in the old people, in the young people, pooling the continuous data where there is a different length of stay, cost of hospitalization, percentage requirement of mechanical ventilators. So that is called meta regression, continuous data analysis. Then you are having some of the sensitivity, specificity, positive predictive value, and so on. So that's also, sometimes we call it meta-analysis, sometimes we call it umbrella meta-analysis. Umbrella meta-analysis means meta-analysis of different meta-analysis. So that is the meta-analysis, meta-regression, umbrella meta-analysis, sensitivity, specificity analysis, or one more I would like to add to that thing. We are using the simple word pooled analysis, which means you collected, let's say, the rare disease, Dravet syndrome. Dravet syndrome is that rare, probably you have 1 or 2 case report, you don't have many, but if you search on Google, there are, sorry, not PubMed, then there are like 30 cases of Dravet syndrome is available. Then you manually collect all 30 cases, and then you have your own database of those 30 case report, from presentation to severity to outcome to so many more things, lab data and all gene mutation and everything. And then you do analysis of using SPSS or SAS, and you publish it. That is called pooled analysis. So according to me, all the analysis, when it's involved, the analysis, whether it's a categorical, continuous, biomarkers analysis or case reports analysis, that is called literature review plus systematic review plus analysis, which become your original article, and broad category is considered as a meta-analysis. So don't stick to the heading that, oh, it was a meta-analysis, but you're using case reports and still you're telling meta-analysis. That's fine. Meta word means a combined approach to put forward the outcome in a quantitative way, not a qualitative way. A literature review is a quality work, but the problem with the literature review is you're going to have a big trouble to select the data. So if I want to work on the artificial intelligence in neurology, then I presented a 110 proof to prove how AI is important in neurology, but someone will come and write the letter to editor and say, hey, this guy wrote the whole literature review of 110 different clinical trials showing importance of artificial intelligence in neurology, but look, he missed most critical 10 trials where artificial intelligence is damaging in a field of neurology, but he intentionally did not cover that one. So that's why literature review is not that importance in terms of evidence compared to meta-analysis. So that's a meta-analysis thing. Sometimes we write overviews, sometimes we write a qualitative systematic review. So those things are different type of the things are there: scoping review, rapid review, simple systematic review without meta-analysis, and as I was telling you, umbrella review. So more or less, when you are going to have few observational study, more or less when you are going to have few observational study, you are piling every single thing in one group, and then you publish it with the results, with the numbers. That is something considered as a meta-analysis. So I think majority of you have seen this particular pyramid of evidence. If not, then probably I would like to show you this most important pyramid. Number one is all the way on the bottom of the pyramid, human and lab studies involved. Followed by that, it's not requiring human involvement. It's not requiring even design at all. Sometimes it requires for the grant purpose research proposal. And some people think research proposal means only original study or clinical trial. No, you can write research proposal for case report and case series as well. Whatever require approval through IRB, that require research proposal. Whatever require convincing to the team or convincing to your mentor to be the part of the team, that require a proposal. That proposal is a research proposal. So basically, the word proposal is most common, right? When you want to convince someone what you want, then you write proposal. If you want to do it in research, you write a research proposal. Simple. So the last second evidence is case report or case series. And in the case report, case series, you know that either depend on hospital, either you require IRB or you may not require IRB. In the morning, we had the Emory physician, Dr. Nikhila, very nice case report work. So that's completely, I agree with her that sometime, your hospital will allow you to publish without the permission, and sometimes the hospital screw you if you publish without their permission. So it's all depend on how good your hospital leadership is, right? And followed by that, you have narrative review, expert opinion, editorials, and some of the non-original articles which you can write it. So that does not require basically design. Now, after that, we are having case control study. Case control study, everyone knows case control study happen in the present tense or present current situation. Then you are having cohort study. Cohort study is a prospective study. And after cohort study, sorry, I missed one part. Case control study, after case control study, which is in the past, you are doing it in the past. There is one more, I forgot to write it. It's a cross-sectional study. Cross-sectional study, we do it in the present. Both have the same value, whether you are performing the study in the past or you are doing in the present. Both have same value, and both will give you same thing. They both will give you odds ratio, usually prevalence odds or odds ratio. But better than those, we are having cohort studies. Cohort studies are prospective studies we are doing in the future with the possibility of getting relative risk or risk ratio. And cohort study have the highest amount of evidence when we discuss about let me just write it here. Highest amount of evidence when we are discussing about non-intervention study. Non-intervention study, it does not require any type of intervention. So those are non-interventional studies, and the highest evidence is of cross-sectional. Highest evidence is of cohort. Why people like cohort study? Because it will give you a very accurate possibility of developing disease, very accurate possibility of having death, mortality, morbidity, survival, every single thing. But still, the issue is long-term follow-up, a lot of money requirement, IRB approval. You have to prove so many things, non-harm to the patient, to different committees, ethics committees, and also attrition bias is a huge headache. Even though you have $1 million to run the grant, you are having attrition bias where people or patient lost the follow-up, and down the road, study will not publish because of not having appropriate sample size. So maintenance of the sample size is a huge headache in the cohort study. So after that, we discuss about the randomized control trial, and randomized control trial is the whole different ballgame. Clinical trials or randomized double-blind, single-blind, triple-blind studies. Why I'm discussing that? Am I discussing clinical trial or anything? No, we want to reach how important meta-analysis is. That's why we are mentioning all this background for that particular thing. Now, after randomized trial, I'm putting meta-analysis all the way on the top, and critical practice guideline on the top of meta-analysis and RCT, because guidelines are designed on a basis of multiple meta-analysis or multiple umbrella meta-analysis. Now, meta-analysis usually are of, as I was telling you, that different type of analysis are there, and that decide type of meta-analysis as well. But on the other part, when you are combining the result from the several similar studies, then the word similar is important. So other part, what type of meta-analysis exists? One thing is meta-analysis, meta-regression, pooled analysis, sensitivity, specificity analysis, umbrella meta-analysis. That is one side of a meta-analysis. But other side of meta-analysis are meta-analysis of clinical trials, meta-analysis of observational studies, meta-analysis of case reports, or mixed meta-analysis. That's another spectrum of meta-analysis. So either you are going to merge all randomized clinical trial and use PRISMA protocol. We'll discuss quickly later on. PRISMA is a preferred reporting guideline for systematic review and meta-analysis that is exclusively for clinical trials. Or if you don't want to use the clinical trials meta-analysis, you are having observational study, three case control, two cohort, one cross-sectional. Then you are having like a group of 7, 8 observational studies. And if you are going to utilize again the guidelines, standard guideline, and then you are going to again merge the data of that, and you can publish meta-analysis from observational study. Similarly with case report, and similarly if you have only one clinical trial, 2 case control studies, 15 case reports, what do you want to do it? Then you are going to merge in a mixed manner, and then you are going to publish meta-analysis out of everything together. So the highest value is of meta-analysis of clinical trial, followed by that meta-analysis of observational study, pooled analysis of case report, and so on. All right. So this is the most important pyramid. And when you are working with any type of reviews, make sure that literature review is all the way on the bottom, followed by that qualitative review, which is the systematic review a little bit up, then quantitative review, meta-analysis all the way on the top. And in the meta-analysis itself, as I mentioned, clinical trials meta-analysis comes all the way on the top, and then observational study and so on. Now, one thing I would like to emphasize the difference, and that will also cover our most important part, why observational studies or meta-analysis are important than simple literature review. Before we jump into why it is important, let's discuss about what is the difference between them. So the literature review is a qualitative summary. It's a qualitative summary or collection of the evidence on a particular topic in a way that you collect the studies and you interpret the study the way you want. Maybe a good way, maybe a positive way, maybe a negative way, but it's a simple synthesis of written evidences. So one study is telling the prevalence of cardiovascular disease in United States is 15%. One study says it's 20%. One hospital data says it's 5%. And one study published in the Athletes say only 2%. Then there is no way to do analysis for you. In that case, you can write it, the prevalence vary from 5% to 20%. The lowest among athletes, 2%. You write it in your language. So that is the way you synthesize the evidence. And you write the overview, or you write the summary on a topic. Okay. But when we discuss about the systematic review, then you have a primary research focus question. You identify, you select, you have inclusion criteria, exclusion criteria to synthesize the evidence, and you produce the high quality evidence. We are emphasizing the word on evidence. Why it's a high quality evidence? Because you do have the method, you do have aims and objective, you do have a systematic search, and you also have the international guideline to publish the systematic review and meta-analysis as well. Now, for that one, we are using a specific thing. We call it PICO. PICO is a population, intervention, comparison, and outcome. We use that strategy to work on that one, right? And the component, when we discuss, the component must be the pre-specific eligibility criteria, systematic search, validity of the finding, interpretation of the finding, and the reference. Compared to that, we are having here introduction, discussion, conclusion, and reference. We do not have any other criteria to deal with it. Now, we can have here in the literature review, probably one person can write the full literature review and you're good to go. One person can write the full literature review. Systematic review and meta-analysis require minimum 3 authors. Why? Because when you are going to go through the different methods have phase 1, phase 2, phase 3, phase 4. Phase 1 is, for example, using Pico search engine and identify 10,000 article maybe. But the 10,000 article is selected by Dr. X and Dr. Y. After using inclusion exclusion criteria, what should be finally included in list? That will have always controversy. One person say, no, only 50 are in my list. Another say 55 in my list. So the third person will intervene and hey, will use the veto. No. This should be the final number, not 50, not 55, 52, or 55, or 50. So that is the third person is required always for the phase 1. And similarly, they have many phases in order to finish that methodology part. So you require minimum 3 author. And if there are 3 phases, you can go up to 9 author, 12 author, 15 author, and I have seen up to 300 authors sometime if the study is a bigger one, right? Of course, it should be having a specific timeline, specific month to year. Let's say some people use the timeline of 10 years, which majority of my study use. Some people use 1 year, 2 year, 3 year, but on an average, between 2 years to 10 year could be a good timeline in the past to collect the article. Compared to that, in literature review, you can like literally use the timeline that within 12 months, whatever is published, you can utilize that. You don't have to go in the back date and then dig into more material. Because if you're going to search, for example, monkeypox, most common literature review, maybe everyone wants to write. But if you search, there are 50 articles, you will see it last year published on monkeypox. Simple. If you want to publish something, you have 50 articles. You don't have to go to last 5 years, 10 years, 15, 20 years. So that's how the timeline can be decided on this particular type of study. Now, requirement means what do you need, especially in order to complete that. You require a thorough knowledge of topics, and that's why it's very popular in residency and for the fellows going for promotion, going for fellowship application, going for assistant professor level of position. This is most important because it's very fast. You don't require IRB. And if you want clinical trial, grant for clinical trial, you at least should be having 10 manuscripts. How would you bring 10 manuscripts overnight if you want money, let's say next year to execute your study? So this is the best way to expedite the work. So thorough understanding of topic is required here. But other than that, here we require thorough understanding of topic, literature search understanding, database understanding, and analysis understanding. But this is very powerful tool when it comes to structured abstract and structured manuscript. And why it is important or valuable over all other things, because it will create very high quality of evidence with the extraction of the all clinical trials or literature or systematic reviews or observational studies. Not only that, it will give you a quantitative numbers attached with each different outcomes. Not only that, but also we will have whatever we publish that is going to have a highest acceptance, because that will give you, let's say, one clinical trial occurs in US Texas, in US New York, in US California, in US New Jersey. We call it, let's say, same clinical trial, same company, let's say Pfizer, on COVID. So Texas more or less having more Caucasian people. New York is having a mixture, but mainly African American if it's a Bronx study, or Mount Sinai, let's say. California will be having mainly Asians and Hispanic origin, and let's say New Jersey enrollments are having only Indians, let's say, right? So whatever results are produced after clinical trial, that's not uniform. Internal validity may be high, maybe heterogeneity is low. Heterogeneity means interstudy variability. Interstudy variability means if I'm doing it, if Dr. X is doing it, if Dr. Y is doing it, what is the difference in the blood pressure? You know that, right? For example, using the same type of mercury machine. So now interstudy may be low because it's the same company, same vaccine, same trials, same inclusion exclusion criteria, but still different race, ethnic and racial backgrounds are different. So to reduce inter-study variability or increase external validity. Increase external validity. If you are going to do systematic review and meta-analysis of those 4 clinical trials, it is a huge impact because now it will apply to the whole United States population. But think about one study in US, another is in China, third one is in India, fourth one is in Ghana, fifth one somewhere else. Then meta-analysis will reduce the margin of errors and try to give you the global aspect of anything. So that way, this creates the highest evidence in the section of the evidence pyramid. Okay, I'm going to quickly go through the whole cycle, what we are doing it. First of all, we decide brainstorming of idea, questions. Followed by that, we search on the scoping of the research. That means whether it's a possible or not. For example, I want to open a shop. Let's say I want to open simple Dunkin' Donut here in my next to my home. Of course, I will search within 10 mile or 15 mile or 20 mile, is there any Dunkin' Donut or not? If there is, then there is no meaning of opening it. Then you either go to other shop or go to other place, not other shop, go to other place where there is no Dunkin' Donut in the periphery, or you change from Dunkin' Donut to Taco Bell. Makes sense? It's the same thing. You do the scoping search, you realize that there are 15 different meta-analyses are there published in last 2 years, and you still want to publish meta-analysis. I'm telling you no. So usually people teach their students that, hey, no, we don't want to publish meta-analysis. There are already 15 present. And I will teach you that, hey, hell no, merge all 15 meta-analysis and make umbrella meta-analysis. So that means you are still living in the same community and you are changing your brand. Now, this is not going to be the same brand, which that's not going to be the meta-analysis of let's say 5 clinical trial or 10 clinical trial, but you are going to collect all meta-analysis published in the last 2 years and then umbrella meta-analysis. Option 1 or option 2, that 15 meta-analysis came out in the last 2 years, but the last meta-analysis came 6 months ago. After that, there is one more clinical trial published. Then I'm going to mix this 15 plus 1 clinical trial, and I'm going to publish again new meta-analysis. And then I'm still happy. I don't need to change the topic. So there are multiple ways you don't want to change the topic. I will change a little bit of outcome, and the same topic is ready for meta-analysis. Right. Just now in the morning, I had consultation. There are 3 publications published in PHQ 9 category evaluation of primary depression in a outpatient, and one was in the inpatient, outpatient, and somewhere else. And then one of the resident doing residency in ED in India was asking that why not I can use the same thing. And I was like, what will you do? Prevalence is already there or incidence is already there. He's like, no, I'm going to change it to emergency department and we'll see how depression, identification of depression before admission or during admission will change the overall outcome. I was like, okay, do you have other study published on that? He shared with me 4 same study. I was like, copy and paste exact same studies, just change the setting. So population is not anymore outpatient population will be ED patients. Done. The same study replicated in the second field. So the scoping search will help you that you want to go with the same study or you want to change your study. So that is, we call it scoping search or brainstorming of the idea. Now, after using those umbrella meta-analysis or something else, if you want to, that's up to you. Do you have dare to publish in a good journal, higher impact factor than non-PubMed index or PubMed index? Those all are the separate horizon. But can you do it? Yes, you can do it easily, and still you can publish the work. Followed by that, you work on the protocol, and then after you generate your protocol, you do the full search this time, and then you decide your title and abstract screening, that what you want to do it. After you are having a screening, you use the full text retrieval using Pico. I strongly recommend to begin with only PubMed and then jump to Scopus and all other things, but up to us. But you just go through one directory. That would be the better option for you because it will make your project quick and easy. After that, you go to the full text screening. once you have full text screening, you make sure if you want to use some additional screening for secondary aims and objective, it's good. If not, then you collect the final number of the article. As I mentioned, included references upon all people are agree or not, all three people agree or not. Then you use data extraction sheet, then you synthesize the evidence, and after extraction you do analysis. Of course, that means synthesis of the evidence, and then you write up the thing and then you publish it. You can publish in the conference as abstract, because this will become original study with the intro, aim and objective, method, result, and conclusion. We call it structured abstract, original abstract. We'll easily go and publish in the good journal, good conference. Followed by that, you write the manuscript and then publish in the conference. Publish in the journal. So manuscript is the full depth length of the article, varies between 5 page to 20 page or 30 page. Then you just publish, depend on how good you have written, and based on your team and your mentor's approval, you just publish that one in a different journals. So that's a whole systematic review work. Now, one more thing, the meta-analysis. When we are discussing meta-analysis, when you are planning to decide meta-analysis, which protocol you need to use it, that you can work on, depend on the references you're collecting. Let's say if you have collected 5 articles and all 5 are clinical trials, then you can use simple Prisma protocol, and then you can do meta-analysis on Prisma, using Prisma protocol on clinical trials. Or you can use Moose protocol, meta-analysis of observational study in epidemiology, meta-analysis of observational study in epidemiology. You can use that, and then you can simply use the observational study meta-analysis, and then you can publish it there. Similarly, you can use the Prisma protocol to publish the case report, the pooled analysis using the case report. I will share with you down the road example, so you will have idea that how one thing is different than other, because we have the limitation of the time. So that's why all different type of studies are very difficult to explain, but still I'll show you the example and give you the article to read, so you will have idea that what are this article all about, and then you will have knowledge that how you can publish the same thing. And then similarly, we have meta-regression of clinical trials, or meta-regression of observational study. Very powerful tool. On basis of that, if I share my personal experience, that on basis of meta-regression, we predicted exactly in a mid-2020 how many mechanical ventilators are required. Number one, how many, from the data given to us through CDC and Johns Hopkins, we predicted that how many 2020 need, how many end of the 2020, 2021, how many number of mechanical ventilation required, how many ICUs will be required, how many people will die, irrespective to, on a basis of 6 months of data, how many people will die in the United States and some part of the other country, irrespective to the best treatment is given versus worst treatment is given. So that is something that you can predict. It's a super powerful tool, meta-regression, where the prediction analysis can be very easy. And the simple way of doing it, I'm just telling you, everyone know in their school, high school, this formula Y is equal to mx plus c, when Y is your dependent outcome, which depend on mx plus c. Y is your dependent outcome, x is your independent variable, and m and c your intercept and the slope. On basis of that, you can decide the possibility of having death, possibility of having ventilation requirement, possibility of having accident, possibility of having, let's say, weather report, possibility of having rain today, or possibility of increasing the price of the stock exchange here and there, up and down within 4 year or 5 year. It's a meta-regression is the possibility which we are using in clinical research, but I know many people use it to predict the stocks and predict the weathers. Okay, so this is a very powerful tool. So that is the search category or search strategy which we use it here. in terms of when we are going with the systematic search. First of all, we have the focus research question. Then we have the search strategy, fixed search strategy. We use the search strategy in PubMed. We apply different type of filters, and we finally log our recording. That's how we do the search, and it's easy for us to identify finally the big number. And I think majority of you knows that people write it we started with 1,000 article or 100,000 article, and then we narrow down with the 4 only, and you will be like, how is that possible that you come up with the 1,000 article or 10,000 article and you come up with the 4? So why is we use the different filters to reduce or narrow down the number of evidence based on what we need, or indirectly based on the inclusion and exclusion criteria. We use focus search questions using PICO, population, intervention, comparison, and outcome. That means we are going to use, for example, I'm just going to give you one good example. I want to study the role of dual antiplatelet DAPT versus aspirin monotherapy for the management of recurrent stroke, right, in the patient of USA. Then my population of interest is what? My population of interest is what? Anyone would like to write it in the chat box? If I want to study this dual antiplatelet versus aspirin monotherapy in the treatment of recurrent stroke within US, then what will be my population? What will be my intervention? What will be my comparison? What will be my outcome? What can be the outcome? Anyone? Would you like to write, guys? Let's make it a little bit more interactive. Yeah, Esha, you can unmute yourself.
Yeah, I welcome the participants to type in the chat box.
Oh, yeah, you can type in the chat box. Or Esha, you can answer. Try to answer.
So, can you repeat it
so
again?
we are having dual antiplatelet therapy and aspirin monotherapy for the management of recurrent stroke. Okay, this is going to be simple prospective study. Think about that. You are having today 50 people with the stroke, and then you want to apply some group this one and some group this one, and you want to check the outcome. Then let's talk about what will be PICO. Someone wrote it, population will be USA, intervention will be DAPT, comparison will be aspirin, and outcome will be stroke. So someone
Yes,
wrote
sir.
like that way. Someone else will be.
So someone else's population will be patient taking DAPT.
Yeah, I mean, you can give 1 or 2 answers, then I can go. Population will be stroke. Mahavish Siddiqui said population is stroke. Intervention is 1 arm aspirin and another arm DAPT, or yes, and then intervent. Comparison, what will be comparison and what will be outcome? Dr. Siddiqui. So yes, so let's put the answer. It's a very correct answer, partial correct, I can say. Okay, comparison will be the same people. Okay, that's what he wrote it. So basically we are having US population. In US population, we are actually studying the stroke people, right? We have in hospital 50 stroke admissions. So population is the people admitted to the stroke unit who's US living people. So the population of interest will be the stroke. Okay, intervention arm 1 is a DAPT, and intervention arm 2 is going to be few people will be given aspirin monotherapy and few people will be given DAPT. So intervention arm 1 is DAPT, intervention arm 2 is going to be aspirin. Now if it is clinical trial, then we put those 2 arm in the intervention category. Okay, if it is not clinical trial, and if it is simple observational prospective studies or retrospective prospective study, still it is considered as a comparison. You are comparing the DAPT in one side and aspirin on another side. So it's called comparison. So both way the comparison and intervention will be the same thing here. And first outcome, I already tell you that we want to reduce the recurrent stroke. So the first outcome is recurrent stroke. The second outcome could be the possibility of poor outcome, possibility of better outcome. So poor outcome, we can divide into so many different way. I usually divide my outcomes in this way when it's a study specific. I divide outcomes into 3 category: outcomes within hospital, outcome inside the hospital duration, outcome upon discharge, outcome post discharge. So within hospital means mortality, morbidity, length of stay, cost of hospitalization, complication 1, 2, 3, 4, 5, drug compliance is yes or no, so many within hospitalization. Upon discharge means upon discharge chances of death, upon discharge disposition to non-home, disposition to short-term skilled nursing home, physical therapy, occupational therapy, and so many things upon discharge, mortality chances. Post-discharge, chances of readmission of same reason, which is stroke, readmission because of arrhythmia, readmission because of 3rd, 4th, 5th other reason, and predictive model of readmissions. So those are the 3 way of dividing outcome. Other way of dividing outcome in my languages are: number 1, patient-specific outcome, mortality, morbidity, readmission, discharge, all those things. Hospital-specific outcome, cost of hospitalization, length of stay of hospitalization, burden on the hospitalization, and doctor-specific outcome. Depend on the volume of the procedure, doctor can save the patient's life in a better way or not. So it's this is doctor-specific outcome. So I can divide outcome in this way, correct? I can divide outcome in this way, correct? So it's a 2 way to look into the outcome. So you can have a full lecture on outcomes, how to identify outcome actually. So basically, it's very important. If you do not know what is the population, what is intervention, what is outcome, you cannot proceed with systematic review followed by meta-analysis. So you should be very clear about what you actually want in terms of population, in terms of intervention, in terms of comparison, in terms of outcome. Followed by that, we use the search engine using and or technique. I'll share with you what is and or technique. So if someone wants to address me, then you can address me multiple ways. For example, Dr. Mansuri in his banner addressed me with Urvish Patel, MD, MPH. Esha started with Dr. Urvish Patel, end up with Dr. Patel. So there are 3-4 names. You guys use it during the whole talk to address me. Similarly, to address any disease, you can put 3, 4, 5 names. For example, simple myocardial infarction. You can use the word population of interest is myocardial infarction. You can use acute MI. You can say MI. You can say AMI. You can say coronary heart disease. You can say CHD. You can say cardiovascular disease. It's the same name, right? For the same population. If I'm talking that I want to study cerebrovascular event, then how many ways you can write cerebrovascular event? CEVD, cerebrovascular event, TIA, transient ischemic attack, AIS, acute ischemic stroke, subarachnoid hemorrhage, or SAH. So paper published in different names. So all names goes in the population, and we use or word to identify one group of people. Then let's talk about intervention or comparison group. If you are comparing, let's say, COVID and no COVID people, how many ways you can write COVID versus no COVID if you want to search them? Coronavirus disease 2019, COVID-19, COVID-19, then SARS-CoV-19, and then something else, and then something else. So there are many ways to write. So you can use again or between different name of COVID. Outcomes, you can write or between outcomes. When you are using or, then you are going to try to cover as many articles as possible. So I'm just writing here so that you will have idea. What is the difference? This is the cohort A, this is cohort B, this is intersection between cohort A and cohort B. So when I'm going to use the or A or B, this that means TIA or transient ischemic attack, then I'm going to get the all article which is having written this way. That will give me more article. Remember that. Even though you think or means small number of articles, no, or means big number of articles. So we are using or between all of them individually. And then we are using this final search engine that I want population and intervention and outcome together. When we are going to use the word and, then we are going to use this middle where both should be there. There should be the name of TIA also. There should be the name of transient ischemic attack also. So this is very important when you are dealing with and or technique. According to me, or is a broad search engine and is narrowing down on a search engine and or. This is most important. You need to make sure about when you are using and or. When you are using not, by the way, if I'm using that, let's see, I want all the data on ARDS, but not on COVID. What does it mean? It will give me all the data on, first of all, ARDS. It will give me all the data on ARDS, for example. But if there are some studies where ARDS because of COVID, it will delete it. So not is also a good strategy to use. So basically in systematic review and in meta-analysis, we play with or and nor, not in order to get desired number of articles, basically. Followed by that, this is, look at it, it is mentioned population, all population use the term 1, term 2, term 3 using or technique. And then we have determinants or exposure or comparison or intervention using again or technique. And then we are having outcome also using or technique. But when we are merging P, I, or C and O, then we use and technique. So we need to play with those techniques to narrow down the final number of the article. And here is the one example of that. So tobacco and smoking both are same thing. So we use or. But when I'm dealing with the population of tobacco, let's say outcome cancer develop or not, then I use the and. Population of tobacco, disease develop as a stroke, and, right? So this is the way you identify, you use the and or technique in order to get your final number. And finally, as I'm telling you, that you need to keep the search recording for each and everything in order to get your exact number of item. So for example, I'm just defining the terminology in terms of we are having 3 examples: COVID-19, outcomes of COVID-19, and vascular disorders. Now, because COVID-19 patients we want to study, that means I'm starting COVID-19 as a population of my interest. I'm going to write so many different names of population of interest using or category. I may diagnose COVID using EPIC data. Radiologist may diagnose using CT data. Lab pathologist may diagnose using RT-PCR data. Different way you diagnose so that you can define inclusion and exclusion criteria. But once it is diagnosed, we put it all search using or search engine. As I was telling you, there are multiple name of the outcome: ICU submission, admission, oxygen saturation, invasive mechanical ventilation, severity of the COVID, in-hospital mortality. This all goes with each other using or. Vascular disorders are of many types: hypertension, CVD, CVD, pre-existing vascular disorders, uncontrolled vascular disorder as generated as a new onset of complication. Everything internally will go with or. But now when I'm dealing with the search engine, I'm going to use it and. I'm going to use it and to merge together. Now, before we jump to this, the search strategy, just give me 1 second. So you will have exact idea about search strategy as well. So we can apply that search strategy to the PubMed, basically. So now here I'm having the PubMed where I use the word stroke. I'm going to use the same example, dual antiplatelet versus aspirin monotherapy for the treatment of stroke. Okay. So here I put the stroke and I put the search. How many articles are coming? 414 articles are coming. 414 articles. Now, am I going to use in systematic review and meta-analysis if I want to study the same concept of DAPT versus aspirin monotherapy for the management of recurrent stroke? Whether it's a systematic review meta-analysis, whether it's a simple systematic review, am I going to use all 400,000 articles? No, I'm going to use exactly, it's too many. I'm going to use the advanced search engine, right? Then I will be making sure I will decide my population of interest, and I will put here title and article with the stroke, I'm going to use it here, or I'm going to use it, or followed by that I'm going to use the another name of stroke, acute ischemic stroke, and or then or, right? Then AIS, or then TIA, or then transient ischemic attack, or. So it's a pretty decent amount of the terminology I use it. You use sometime NLM, National Library of Medicine, to decide, but I'm just right now writing just from the experience. So now I'm going to search. How many it become? 48,000 only, which is 10% of previous article. I don't have capacity for 48. Let's discuss the intervention group. We had it aspirin monotherapy, right? So I'm writing aspirin, or dual antiplatelet therapy, or clopidogrel, or. So I can add more. DAPT itself, sometimes people use DAPT, it's a very popular term, or. Then I'm searching. How many search article I'm getting it? 63. I'll go back to search. I'll do #1, #1, #2, using this time, and very nice, Osman. And I search, boom, 32,000 only 32,000. Now, on top of that, I'm changing my date, publication date. Can anyone tell me where is that? Here you go. Date of publication. I want since 2010, 01/01 to present. Search. I'm going one more time in advance. #4, #5. And what number of the the ideal is finally what you are getting it. And after finally what you are getting it, if all three are agree on that number, then that's the final number. I have seen people take a shortcut. What is the minimum number is 3. What is the maximum number? We have done it highest with around 72, 73 till now in one systematic review. Now, according to me, minimum number is important, because if you don't have more than more than 3, then you cannot do it. So minimum number is 3, but if you are doing it for, let's say, 7, and if by chance you intentionally miss 15, then they will tell you once you submit in the journal that, hey, another 8 you intentionally miss, add all and republish or resubmit the article, and that time you will be screwed, because that time you have to change results, discussion, and every single thing. So if I'm there, I use a very small change in inclusion and exclusion criteria from the beginning, if I don't want to deal with 100, 110, and if I want to publish it for the teaching point of view early. Okay, but the maximum, there is no number. Ideally, what software is telling you, that number should be there. So total 25 articles are coming, right? After 25, after this 25,000 article, I'm using always not free, full, or abstract. I'm using full text, even though it's not available, let's say, in US, but you can use different, in the morning, Dr. Nikhila was telling that you can use different search engine website, or you can ask your friend to give you subscription of PubMed and to download. So free full text, I'm going to use it. Then I'm going to, you can put the link even, Usman, if you know that. Then we are having humans. We are having English text. We are having English text. See, number is reducing time to time, right? Then we are having randomized control trial. Then you're having multi-center study. Then you are having clinical trials. Then you are having phase 1, phase 2, phase 3, phase 4. I don't want to put phase 1, but still phase 2, phase 3, phase 4, I can write it. That's good. I have 2,947 studies to evaluate finally, which is very easy to do it. I'll show you how, but it is very easy to do it. But then you download. So if you see the search bar on the bottom, you can get that search bar, and that will give you the final history. And that will show you something like this, which you submit in the supplemental material before you publish or before you submit your article to review. Now, in 2947, you go one by one quickly, open the abstract and read whether it is good for you or not. Is this good for me? Yes, I will put it in the Excel sheet. The data collection templates, people make it, and those data collection templates, you need to make it to collect the data on population intervention comparison and outcome. You narrow down properly, trust me, from 2,900 only 20 to 30 studies you require to finally full evaluate from abstract to manuscript. You don't have to download all those 2,000 studies. No, you only need to read the abstract quickly, skim that. Like literally 300 abstracts like last week we evaluated in 1 hour of time. So it's very quick once you are good in that one. Finally, you are only going to go through 20 to 30 manuscripts, and then you will be applying your data filters in that. 10 to 15 manuscripts required to go down, dig into, and collect the data. So data will be collected for analysis purpose. So this 10 to 15, according to me, is called quantitative studies. And this 20 to 30, according to me, is called qualitative study. I'll use that studies in my discussion writing, introduction writing. So it's my qualitative studies. So we are basically playing with this small number of study. Once you think everything is good to go, then you can simply jump to Prospero, like the way everyone knows clinicaltrial.gov, right? Clinicaltrial.gov. I'm just putting like that way so we can, So this is the government website where you register your clinical trials all across the world, not only United States, everywhere. Similarly, Prospero, we register our meta-analysis every time. Once you register the meta-analysis, then you can go with the beginning of your study. But I'm just going to share with you. I have one right now, which I made it for you guys, that you can have an idea of what it contains and what it's not contained. This is the, oops. Okay. This is a stem cell therapy in the neurology disorders. You require a title, language, participation date, when you are going to do preliminary search, selection criteria, eligibility criteria, data extraction, risk of bias, data analysis, you have started or completed or not, then contact person, then phone number, then detail of institute, all those things, conflict of interest, what is going to be your question, aim, and objective of your study, right? How you're going to use the search engine, search date, what is the dates you're going to use, what are the search string you are going to use, who's going to be the independent reviewers, who's going to be the dependent third author, all those details one by one you go. And there are total bias assessment, risk of bias assessment. I will go through in example article. I'll open example article and will show you all those things. You will go, total 40 criteria are there. Whatever you require to fill it up, you fill it up and you download, and then you start working on your Prospero guideline. And then you simply collect the data on your population intervention comparison and outcome, and then you run the analysis. Now let's jump to what are the software required, what are the things you need to do, so you will have a little bit of idea. I'm going to share my screen. Just give me 1 second. So once you collect the data, you have some softwares that can help you to work with your project. What are those softwares? Software number 1, you can see right now, Revman, Review Manager. Software number 2, Comprehensive Meta-Analysis Software. Software number 3, Open Meta. And there are many more softwares, but these 3 are most common softwares which everyone is using nowadays. So I'm just going to share with you that how this usual projects goes. Once you have software with you, then you start with your actual study, what you want to do, whether it's an intervention study or not. You go with that. You put intervention 1, intervention 2, for what problem you are doing it, and you are going to have the full length of review. Then this type of window you will have it. After you have this type of window, you decide whatever study you have decided in inclusion criteria. You can add all the studies characteristics here. You can make sure about adding your studies in a way that you will have it, let's say Patel et al. Then you can, this is only for published data. You can add a year, let's say 2020. And finally, you can have second study there. That's how you can have one by one each study. And you make sure that once you have studies added, I'll share with you. I have prepared one for a quick showing you of that, how we can add all studies together. You can add all the study one by one. Someone asked me how much is the maximum. Maximum is whatever you are getting it. How much is the minimum? Minimum is what 3 probably are the minimum one. And I'm just going to add more studies. So just gonna share with you. This is one study. That's a title. So you add the same way, adding the studies, and you're going to have 3-4 studies here, included studies. Can you see that? Then you start working on the type of the data, whether I was telling you, whether it's a quantitative data quantitative data, there are two types of quantitative data. What are those two types? Death occur versus did not occur, yes or no, binary outcome, or depression, let's say, before treatment and after treatment, before treatment and after treatment, before giving placebo and before giving, so before treatment, so before giving placebo versus before given midazolam, or after giving placebo and after giving midazolam. What is your depression scale out of 1 to 10 with mean reduction or standardized mean reduction? What is going to be the scale, right? So that is a longitudinal data basically we are discussing here. So based on that, whatever you are doing it, you can simply add the comparison. If my comparison is, let's say, the mortality, then I'm looking into the mortality, and I can look into the short-term mortality, long-term mortality, 30 days in hospital, 60 days, 90 days, so many more mortality. I can look into that. And then in mortality, I'm having here, I'm adding right now dichotomous outcome for 30 days mortality only, for example. And I'm going to keep it between, let's say, DAPT and aspirin monotherapy, same thing. And I want odds ratio between that. So you go through one by one, this, you follow the step, read, it's very well clearly written. And here you go, you are having very nice two different windows to work with it. And then once you add your studies, I'm going to show you actual data, because you randomly add the studies, it will not have any value in terms of creating this graph. So I'm just going to share with you one study, one of the example study from the team, so you will have idea that what they did to publish the work. So here you go. So this is going to be possibility of hospitalizing the patient with the COVID in terms of when someone smoked versus someone did not smoke, right? So you are having event, means hospitalization occur. Yes, out of 100, let's say 5 people hospitalized in the smoking category, and never smoking category. Out of 200, only 10 hospitalized. So you put study number 1, study 2, study 3, study 4. It will be keep producing you odds ratio and relative risk, whatever you want. This is, we call it forest plot. Why we call it forest plot? And this is called diamond. Okay, so the diamonds are the final value of forest plot. The forest plot, we call it forest plot because it looks like forest, and it looks like my favorite Christmas tree. So it gives you the confidence interval and actual value, and it pulls the data with you, and then it will help you to give you final result. Final result, you will be getting it with heterogeneity. You are getting it with the overall effect, tau square. It's a full detail. I mean, usually it takes us to teach someone 2 months the whole concept of meta-analysis and meta-regression. But this type of very nice graph you are producing, and once you are downloading that graph, then you are going to have a decent graph. If I don't know, you can see here or not, you can see probably here, right? So you can have a very nice graph, and then you can do risk of bias assessment on basis of that. The risk of bias assessment is a whole different ballgame, but still you use different type of biases, selection bias. Everyone who finished their STEP exam, they know what is the risk of bias assessment. Selection bias, performance bias, detection bias, attrition bias, reporting bias, and so many more. So you do assessment, and you finally come up with the final number of bias assessment. So this is the way we run the full data, whether it's a one type of data, whether it's a second type of data, but multiple type of data we run, and then we create such thing so that it will help us to finally interpret different type of meta-analysis. So I'm going to now share with you 3 to 4 different type of meta-analysis, meta-regression, so that you will have idea what are those different type and what type of answers you are getting it out of it. Some of these studies, I'm having it from my own profile, so it's going to be easy for us to. Okay, so let's go with the very easy to very difficult. First of all, we are having it most easy study where we have evaluated COVID in the COVID patient. If it's a pre-existing cardiovascular disease or hypertensions are there, those patients will die more or not. Those patients will have poor outcome or not. What happened to them? See the 40,000 with inclusion, exclusion, and all those criteria we applied. This is PRISMA protocol, by the way. Either PRISMA or MOOSE, depend on that. But in this one, this was not a clinical trial. So instead of telling you PRISMA, I'm telling you it's a MOOSE protocol. But this looks like PRISMA and MOOSE. And when you are typing, both are almost same. The only difference is the name, the invention occurs by different people, and different citations are there. So that's how we differentiate to the different thing. So see, this is meta-analysis for 27 and 28 study, but meta-regression was for 14, 16, for 13 and 14 studies. So that's how we are having different type of studies for different type of outcomes: quantitative, qualitative, meta-regression, meta-analysis. And this is the, if you want to write reviews, 316 studies were there in a final criteria. And then data collection occurs from whatever study. You just put the characteristic of that particular data, right? And then look, then you simple add the data and finally come up with the one answer that if someone with the cardiovascular disease admit to COVID, then the chances of getting composite poor outcome 3.36 higher odds, means 236 odds. Sorry, 236% higher likelihood of having poor outcome. So similarly, this is for hypertension patient. You keep adding one by one. Similarly, you are having meta regression in the same theory. So I put y is equal to mx plus c using software, and then we find out, we put the study 1, study 2, study 3, study 4, 5, 6, 7, 8, for example. Now it will show you exactly that. Let's say in your hospital, 8% people diagnosed with the CVD, pre-existing CVD. In your COVID unit, if 8% people have cardiovascular disease, then what is the chance of, this is, I think, ventilation requirement, okay? What is the chance of requirement of mechanical ventilation? So it is logit event rate, e raised to logit event, so e raised to whatever it is going to be, x number, and then when you put it in the calculation, then it will tell you exact number of what is going to be the chances of requiring mechanical ventilation things. And the same way you go with all different type of meta regression, and then you do the overall risk of bias using different criteria. Some use Newcastle Ottawa NOS scale, some use Robin scale, but this is the exact way you go through it and then you publish. So this is a continuous data analysis. This is the categorical data analysis as well. There are two types of analysis we cover here. Now let me show you the second type of study. So in this second type of study, what we did was, here it is the 110 case of pneumolar headache. 110 case. How many I have personally seen, or any of our team member has seen? 0. None. But still, you can publish the whole original study out of it. How you can publish it, whole original study? I'm just going to share with you that the trick of doing it. We have this supplemental material. Yes, we do have it here. Supplemental material for okay, so this is data collection sheet. And in this data collection sheet, if you see that, how to make it bigger. Okay, everyone can see that? Okay, so we use the structured terminology as I was telling you before, and then we make sure that how many of that people have pneumolar headache. And in that pneumolar headache patients, this study published 3, this study published 1 case report, 2, 1, and so on. And if you see, there are many studies here. I'm going to share with you 101 case reports are there total. We collected at what age it is diagnosed, what is the gender, group, latency from first attack to diagnose, onset of pain, intensity of pain, attack, number of days involved, and frequency, timing, localization, region, diameter, quality of pain, tenderness, exacerbating factors, concomitant symptoms, temporary relief occur or not, total resolution occur or not, therapeutic intervention given or not, which therapeutic intervention was given, and after giving therapeutic intervention 1, 2, 3, 4, what was the effect occurred. By this data collection pattern, another quiz question. Can anyone tell me what could be our PICO here? Anyone? What could be PICO here? Population intervention comparison outcome. This is Excel sheet collection. Data collection is done on Excel sheet, and data was published using SPSS software analysis. I'll share with you what type of outcomes they have collected. But I want you to population, adult and pediatric. Oh, maybe yeah, but it's only one headache, Usman. It's only one headache, pneumolar headache. So population could be what? Population could be, because the study is based on what? The study is based on pneumolar headache, right? So you are trying to evaluate the effectiveness of various intervention on pneumolar headache. By looking, it looks like an intervention study. Have we given any intervention? Answer is no. We just collected the history from different published PubMed articles. So patient with pneumolar headache was my population. What was the intervention for now? Let's not talk about intervention, or you can say all this medicine was intervention. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. What was the comparison? Total resolution of the symptom versus not resolution of the symptom. Or you can put it even in outcome if you want to, but I'm just putting it that total resolution versus no resolution, so we can make 2x2 table to run our chi-square test. I assume that everyone has knowledge of chi-square and everything, because we had lectures of NIS, YRBS, and all those big databases. So, so comparison group will be there, and outcome will be simple. Patient have a complete resolution. Which drug was give you resolution? What is the 100% resolution rate, or what is the rate of different medicine, right? So the whole data is been collected in a way, so we finally have the characteristic of each different population. We finally have the characteristic of each different population. Then after having characteristics of patient, we divided into association of characteristic between pneumolar headache resolution occur versus did not occur. If it is occur, what is the age? What is the gender? What is the latency? What is the age of onset? So you will see chi-square test, t-test, and all those tests you are going to apply for 2x2 table. And you will be coming with median and standard error, mean, or 2x2 table of percentage frequency. Botox was given or not. 30% Botox was given here and here, here and here, yes or no, triptan, TCA, lamotrigine, gabapentin, carbamazepine, every single detail we have collected. And after using that detail, we find out what can be the response rate using fixed formula, and we come up with a number that 67, 65, 100% on Botox, this. Now, you won't believe that by having one case report, you can never prove which medicine will be better than other, or what is the exact characteristics of that disease. Here we prove that what can be the exact diameter of the pain, 4 centimeter plus or minus 0.2. Number of attack, 3 mean number of attack, median number of attack plus or minus 2. Mainly it occurs unilateral, either left side or right side. It can never ever be bilateral. Mainly it's on the parietal lobe, followed by that maybe occipital and so on. So this will give you so many very important consolidated evidence which you can never publish by only doing one case report. Now, I'm just giving you example that how the citation work, because if the quality of the work is good, of course, it will have a more citation. If the quality of the work is bad, it's having less citation. So that is giving 6 citation in 2020. Okay, I think it was a December. Let's see if we are looking exact month, so we will have idea. So we talk about citation comparison, then why it is important to publish something like that. We are having publication date, I think March 2020. And I'm having, so basically March to April, so 1.5 year of duration here. And I'm having, let's say, another review article, which is, no, a case report. Let's talk about case report. Case report, we have few case report here. So one is this one. This is not only case report, this is the case report and the review article. So this is not sole case report. This is sole case report or case series. I'm having it 0 citation. I'm having it here, but I hope that it will be more. But I'm just giving you example that when you don't have condensed evidence in terms of substantial value to make a guideline, then case report, even though you have one case report, it's not that helpful to give you the guideline related weightage, right? Is it important to publish case report? Hell yes. We want as many case report as possible in a shorter period of time when you're applying for residency, because what residency people know is average number of publication on a day you apply. But once interview comes, then average number could be 30 for you. Let's say they will ask you out of 30, how many are the manuscript and how many are the posters? Out of manuscript, how many are the original research and how many are the literature review? And let's say I'm sharing my personal experience. I was also asked that, why are you having 30 abstract and only out of 32 were converted to manuscript? Why? You did MPH. By the end of the MPH, you have 30 abstract. Average MPH graduates are having 3 to 5 max. Okay, max. I have 30 here, but only 2 manuscript. Why? And the importance was, in the morning they were explaining open access, non-open access, article processing cost versus non-article processing cost, all those complicated concepts they were explaining. So I have only 2. They ask you that, can you able to complete that by the X amount of the time? If these are good article, XYZ article, you have to complete before we rank you, before you start residency. If it's a fellowship applicant, they're a screw if you have that many abstract and 0 manuscript. So they will tell them, hey, convert it into the full length manuscript, because without manuscript, you don't have guidelines. So abstract increase the mean number of publication to receive the interview, because they put it in filters, how many mean number of publication you have it. But once you have interviews, to have yourself rank higher, to have a long impact memory on program director's mind, like a footprint on PD's mind, you require manuscript to discuss more findings. And that's why we prefer our student or people whom I know that, hey, take your interview in November and December and January. If you are going with the simple match program instead of pre-match program, you have 2 valuable things happen in the November and December, January interview. Your knowledge of the interview is a fresh. You can simply remind on a second week of or first week of February for a rank before rank order list that, hey, XYZ, I interviewed your program, letter of intent is here, and I really like your program, whatever. So that way, between January and February, you have a narrow amount of the time for the memory. And also you can publish, you can convert so many abstract into manuscript. So by that time, you can say that by September, my CV has this thing, but think about I converted this many more into manuscript. So down the road for residency applicant, number of abstracts or number of case reports are a good thing. But to rank that thing, to rank yourself higher enough in a 2 to 3 cycle, manuscripts are important. To go for fellowship interviews, manuscripts are important. To go for green card, which you have previous lectures, manuscripts are the only importance. And to go for promotion from clinical assistant professor to assistant professor, AP to associate professor, PubMed index manuscript are the most important. So here is the hierarchy of whole career, you know. So this is the example of pooled analysis. Get back to our work. Followed by that, I would like to share with you one more before we jump to the other one. Just give me 1 second. Okay. Here you go. The third one. So this is a pooled analysis, by the way. And the third one is the simple systematic review I would like to show you without much detail into meta-analysis. Let's say which one is the first one we can, okay, we can have it this one or this one. It's even easiest one. Okay, this is simple systematic review, no meta-analysis involved. What happened? Just give me 1 second. Here you go. Okay, so I think it's a delayed projection. Okay, so basically when you are looking into this manuscript, it's simple systematic review, no meta-analysis. I think there is some issue with. Okay, by that time we can just look into here instead of going to. We can go from here too. So basically this is the systematic review without meta-analysis. What they have done was they have collected, it's a background, then introduction part. What they have collected was they use the proper search engine. They use the proper search engine to get the appropriate number of the article. They also make sure that they registered the study. They prepare the table number 1. If I can open it, yes, they prepare the table number 1, that what was the data here, but meta-analysis was not performed. But what they did was out of that table, they come up that what could be the prevalence of smoking among COVID. What is the association between smoking and the poor outcome, line by line, right? What is the limitation of this article? What can you propose interaction between COVID and smoking? What could be the potential harm, what could be the potential beneficial effect, and what could be the conclusion in terms of receptor wise, and conclusion in terms of what could be done in the future. So data was collected. Yes, data was here collected too, but data was not analyzed. Data was simply collected and data was interpreted in a way that you can simply write your result section without meta-analysis. So this is another way to do meta-analysis instead of, another way to do systematic review instead of doing meta-analysis, right? So now one more agenda on this board or on today's panel was what is the importance of doing original research and what is the importance of doing systematic review or literature review and so on. So I can, I mean, we already covered that part, but still I would like to make sure that what is the difference between all different type of the study. So you should be very clear about what is what, because if you're not clear about what is what, then there is no meaning of performing any study. So any study that is having introduction, aims and objective, method. In the method itself, there should be specific setting in which you are performing the study, then what is going to be the analysis, inclusion, exclusion criteria analysis, results action and conclusion, including discussion and conclusion, including limitation and future direction, that is considered as original study. So one thing has to be very clear. Now, systematic review can be original study or not. Answer is no. Some study consider, some journal consider systematic review as original study, but after 2021 guideline, not systematic reviews are original study. It should be attached with the meta analysis, meta regression, umbrella meta analysis, pooled analysis, something should be added to that. It's not necessary forest plot must be there. It should be any type of analysis as I show you, but then only they will consider it for original research. And if it is original research, it will be accepted in the conference and it will be published in terms of meta, okay, in terms of systematic review and meta. Of course, all observational study, all clinical trial, observational study, including retro, pro, and cross-sectional, all three are considered as observational study. And we discuss observational studies data. Dr. Desai explained very well about CDC data. We have other Dr. Jain and other people describe NIS, NID, and so many more data. It's a kind of a chunk list of like 50 databases which you can work on by staying within United States or by staying outside United States. But beside observational study, the best thing if you want to do it is the meta-analysis, followed by that case report, followed by that literature review. And if the case report is from United States or is from India, that's fine. I never tell anyone to publish a case report only. I always tell people to work on case report plus review article. This is the, I'm writing just here, the case report only. This is the last grade of evidence. I hate case reports only. Little bit better than case report. Everyone has their own thinking. Okay, I'm just sharing my thinking from my experience. If someone wants to work with me on case report, this is the minimum thing I want them to do. Case report plus literature review of at least 5 to 10 previously published case report. So it's called CR plus review. A little bit better quality of case report, CR plus systematic way of finding more case. So case report plus systematic search, including method, including result, that will give me case report plus systemic review or systematic review. Then one more step, case report plus systemic search plus pooled analysis, that will give me case report with meta. This is the highest quality of evidence, which I think it should be there in terms of, so we basically teach how to convert your case report into all this different category, and that's how you can have a most important thing. But of course, when we discuss with the candidate, IMG, international medical graduate especially, they want quick publication. Everything wants to be quick. So this is not something you can get it quick. You require the year of commitment in order to fill up all this data, and a big team to collect this whole data to run this thing. It requires statistical knowledge, it requires systematic search engine knowledge, and all those things. So if you are having time, if you're applying next year, then this is the best quality of work you can even produce without any IRB. So now, what should be the balanced research? So I feel that when you are going to have all the publication, let's assume 10, which is a good number, okay? If it's a 10, out of that, you at least should be having 30% manuscript. So we are not expecting more. Only 7 abstract or 7 case report or conference is good. but you still require at least 3 manuscripts to talk about. And then you should be working on 1 or 2 more. So the day before rank order lists are there, you can email in your letter of intent that major updates in your CV, 2 more manuscript published or completed. So that is a one guideline. I like it when it comes to the publication. When now you have 30% of the manuscript or 3 manuscript, I strongly recommend go and publish it in a 3 different journal or submit it in 3 different journal. Even though you submit in BMJ and that it get rejected, that is fine, but you want BMJ submission full stop. For example, it get rejected before you submit on 30th September, that's fine. Then you can resubmit it to lower journal. But if it is not rejected, if it is rejected after your submission complete, you can be very frank that, hey, I submitted to BMJ, get rejected. One of my very nice study, one of my very deserving study published, before it published, it was rejected total 17 journal, and I didn't want to pursue that far just because of I was tired, but the senior author did not want it to publish anywhere. Finally, they published it in a very mediocre journal, Journal of Global Health. But NEJM, JAMA, Lancet, you name it, and I can say it got rejected everywhere. But still, look at that 3 impact factors, still 49 citation, not bad. The only essence was to publish it early, which I missed it. I have very mediocre study in mediocre journal. It gives me more citation because it published right away. So you decide whether you want to publish it early versus you want to publish it late. Okay, so that is a one part. And then, of course, if you see, I'm just going to do Control+F. Just I'm telling you, people tell me that, oh, I don't want Curious, I don't want that. Yes, that's true. I mean, if you have 15 articles in Curious, you don't want it. But if you see that, look at that, how many times in search engine Curious is coming? 30 times. In how many articles? Some of them I rejected. So it's 144 articles. So out of 144, if you are having 30 in Curious, then you can calculate what is the percentage of one journal should be in your article. If it is 3 manuscript, try in a different journal, or at least submit 2 in 1 if you want quick publication like Curious or like even RUJ. And our journal is like, we are trying our best to publish it ASAP in 15 days, right? But still, I mean, I don't recommend my students or anyone to publish it 10 article. If you have 10 manuscript, I don't want you to have 5 in Curious and 5 in Research Update Journal of Medicine. No, I want you to take a risk. After 2 and 2, I want you to take a risk for 6 and go and have little bit higher impact. So there is that wrong to publish in Curious? Answer is no. Is that wrong to publish all article or more than 30% article in one journal, whether it's Curious or whether it's BMJ? Even though it's BMJ, more than 30%, answer is no. So that means you are a diversified, globally accepted author. You know, when we go with the money investment, your parents, or you heard many times terminology, diversified portfolio or investment. Why? Because that's what we want, right? We don't want that every time someone will say, oh, no, you are good because this is that. No, we don't want that. At least you try. You tried for BMJ, you tried for this, you tried for Elsevier, you tried for Walter and Coover, you tried, and then you are having good number. We are having total 210 to be precise journal in internal medicine, pathology, cardiology, and so on, to total 16 specialty. That means it's not only one low impact factor journal, there should be many. So try playing between those numbers and make sure you have a very balanced portfolio, at least 30% manuscript and 70% of abstract. From 30% of manuscript, it should be on a different portfolio, it should be on a different journal, and try to have, if the 7 are the abstract, that clearly tell me all 7 are either case report or original study or between either of them. So those are either case report or original study, right? So then I want you to make sure all case reports should be converted to the manuscript. It's most easy to do it. And at least 50% of the abstract you convert into the manuscript. Try to convert. If you are having time, then write full length manuscript, which is 3,000 word, which usually I recommend. Then you can have it brief article, 1,200 to 1,500 words, or research letter, 700 to 1,000, 1,200 word. You can have it anything, but have it at least. Okay, we don't want abstract of 250 words or 300 words, which is clearly suggesting that you have 15 abstract. That means you don't have either capacity to convert into manuscript or someone else did it on behalf of you. So if you can't make it, then you fake it until you make it. Make sense? So that try your best to convert those things into manuscript by yourself. Even in the lowest category of manuscript research letter, this all are, by the way, original article, okay? All, whether it's research letter, brief article, or full length. So make sure about those logistics. And if program director or chief resident or interview committee have 50% confidence in you that you can convert the manuscript, any project into manuscript, whether it's a community college, chances of you being ranked is 90%. And if you're in university, still chances are 80%. So community college, this skill of publishing manuscript is way highly appreciated than university, because university hospitals have statistician, have their copywriters, have their simple writers, they have MPH program, they can give you support, but community program, they don't have those things. So if you are going to do it for them, they are most lucky programs in terms of publication. So I think we can end up our session there and can start Q&A one by one. Anyone would like to start with Q&A? Yeah, and by the way, also one more thing, that if someone is here resident or faculty, in that case, we are having CME accredited programs. You guys can join us, and then you guys can, your hospital will pay for whole education for your, whether it's a young investigator program, young physician scientist training program, or your mentor-mentee program or training program. We will make sure about having professional development fund or CME activity. We can utilize that one for your help. And then if you are international medical graduates, then we are having installment plan, which will be helpful to learn the research before and partially compensated after you enter in the residency. So that's how we don't want to throw the burden of the money on IMG when you don't have money and you're applying for IV prep and rotation and of course research and stuff. So our program is CME accredited, so we can have some type of payment plan that you can pay everything upfront, but then your compensation will be given to you through your hospital after you match. Now, if you don't match, then it's not gonna be our problem. If you match, then only it's gonna be compensated by the hospital. But of course, we have last 3 years, if you go and ask someone for the match rate is way beyond 50%. It's around 88 to 95%. The people who don't match, usually they are the people in surgery. We have radiology, anesthesia, dermatology. Those people have difficulty in matching or difficulty not to continue PGY2 and 3 and so on. But psych, neuro, internal medicine, FM, it's a great match rate. So feel free to join probably tomorrow and upcoming Sunday free webinars, and you can ask a question. You have it through the website. It's a pre-enrollment guidance. You can ask whatever you have question related to program there. Now we are open for Q&A.
That was a very extensive session, Dr. Patel, I must say. So yes, we can start with the Q&As. The first question I see is, does collaborative authorship in a published article with over 1,000 authors hold any value?
Yes and no. Yes, because the knowledge you are having of 1,000 authors, right? If I'm not using the, I mean, it's not citation, 1,000 authors. Yes, so when you are going to deal with bigger agencies, for example, WHO, CDC, Global Burden of Disease, Bill Gates Foundation, and so on, then it's a very normal to have 400-500 articles. Let me share with you. This is original article, but this is collaborators document. So the manuscript or the project I remember was of more than 1 year project and involving more than 1,000 plus researchers. Let me show you that how big this, let me see, where is the, so now what is the value and why it is important, why it is not important? It is important because by working for big collaborator, here we go. So this is, if you see, all authors, can you see that those are so many authors here, right? So having your name with so many people indirectly will not give you any credit when you are going for green card application, where citation numbers matters, because this will increase your citation, because this use by probably how many people in making guideline, I'm just telling you, 1969 manuscript published on by using this data. But why it is helpful for me, because that's the way I get chance to publish my work with the #1 cardiology researcher in the world, Dr. Valentine Fuster. That's a #1. There is no question as he's the editor-in-chief of JAC, Journal of American College of Cardiology. His 4-minute or 5-minute appointment, if you want to talk, it will be early morning, 3:30 a.m. or 4 a.m. according to me. And before you talk to him, you need to be screened by 4 layers of people. Then he will be on phone with you, even though it's a fellowship interview. So you will get chance to make connection so many people if you are a part of such collaborative group. Benefit #1. And benefit #2, when I'm going to ask a grant or funding, ultimately, that time what they are going to look, they're going to see, I'm giving you $100,000 funding, let's say. Out of 100,000, how many manuscripts in the past you have published, how many citation you have it, what is the H10, H index and I10 index. If you are a competitive person, then they will give you grant between 40,000, which was my minimum grant, which I rotate per year, to all the way when I was a part of RA, that was approximately 400 to 500 US dollar, which my mentors grant. So you can be PI, co-PI, or consultant, but that will be before they give you single penny, they look into this number. So yes and no, green card point of view, those number will be deleted. But once you are green card holder, once you are going for academic promotion, answer is yes. It will give you huge leverage.
Thank you, Dr. Patel, for shedding light on that. I see another question. Are there any tips on converting abstracts to full manuscript? Any strategies to write and divide writing strategies? Something. If someone is converting 10 abstracts, the chance of repetition in discussion, likely how to avoid burden.
Okay, so the good thing is, if you want to convert 10 abstract into manuscript, this is what I used to do it. I can only do 6 consultation project as my first consultation, and as a co-author, I used to give 12 consultation only. 12 consultation means 1 consultation a month. It's a huge amount, right? So what I used to do was, I was always working in a 12 different hospital, 12 different team, so that everyone will be with me for only one study. That means one team will be publishing at least 1 manuscript in a year. 10 hospital, 10 team will publish 10 manuscript in a year, and I'm getting my name in all 10 or all 12. So by working in a different team, you can publish 10 abstract in 1 year. Yes, easily you can do it that way. But the only thing is that you need to know the leadership skills. You need to know what skills you are going to provide in all 10. If you're going to write from scratch, introduction, abstract to manuscript, you cannot finish it before 2-3 months, considering your all burden. So try to work in 10 teams. All 10 teams will be working on 10 different projects. Once publication come out, you are having authorship of 10 different project by having very little intervention.
Right. Thank you, Dr. Patel, for shedding light on that. Are there any more questions? I'm asking the audience.
Okay, sounds great. Thank you so much again.
There's
You have
one last one. Do all meta-analysis need to be registered?
not all needs to be registered, but if you are going in the meta-analysis for non-PubMed, low quality impact journal, then you don't need to register it. But if you are going in Springer Nature, BMJ, those publication house, then if you read their notes of the instruction to author, it's written that all meta-analysis must be registered with Prospero number, and they want Prospero ID attached with their meta-analysis. So then it should be registered.
Another question is, Dr. Patel, that is Nature a good journal for doctors?
Yes.
And doctors in all caps.
Yes, the Nature is the best journal. I mean, I have not published any article, though I review for them as a judge in view, but I have not published my own any article in Nature. So NEJM, Nature, JAMA is still my dream after having 3,000 plus citations. So just telling you reference.
Thank you, Dr. Patel, for shedding light on that. There's another question. Somebody sent it to me personally. Does a publication in a... I don't understand the question. Can you please post the question like publicly? Does a publication in a journal with IF of two
Impact factor.
good or impact of two good or a better journal should be targeted?
Let me share just my example so that you will have a good idea. Everyone has their own journey, but I published my first article in Curious, and my last came out in I have BMJ, I have JACC, I have Lancet. Those I have it. I said JAMA is not there, but I do have Lancet article. So I still started my journey with Curious. So everyone has to start their journey from somewhere, you know. And if you stuck to the one journal, then you are a bad author. If you will be constantly growing, then there is nothing wrong, you know.
Right. Right. So Dr. Patel, there's one more question. Any information on EndNote use for study screening?
No, EndNote, you cannot screen the study. You can cite the study using Mendeley, Refman, EndNote. There are so many software you can use to cite the study, cite the references before you submit. But to screen the study, there are many costly softwares are there. You can utilize those softwares vary between $50, $100 a month to like really, really costly. They can use artificial intelligence criteria, and then it will narrow down all study for you right away. Only the people having at least $50,000 and up grant are daring to use those type of softwares, because you need at least 1 year of subscription of those softwares. So I'm not using, but if you're doing network meta-analysis, there is another type of meta-analysis, network meta-analysis. If you're doing it, then you must require those softwares.
Right. Thank you, Dr. Patel. I don't think there are any more questions, and we're also out of time. So I think we should bring this session to an end. Also, Dr. Patel, if these students want to reach out to you, could you share your contact?
Yes, I am sharing with you my contact detail. And this is my email. And then instead of email, I'm more active on my WhatsApp. So I think probably more than 1,000 people. I know me and Dr. Mansuri, we always talk. We are like trying to connect with as many people as possible in any day. So yeah, that's my WhatsApp. You can text me and whatever question you have it.
Thank you, Dr. Patel.
And
so
I meet people on my website. There is the free link. I meet people for 5 minutes. We are having around 4 appointments or 5 appointments in a day. And my coordinator meet around everyone for 2 hours on every Sunday. So if you want like extensive discussion, then you can meet her every Sunday. But I have everyday appointment. I put it in a previous classroom that you can have it for 5 minutes or 10 minutes. Every day we have it. Yep.
Right. Thank you, Dr. Patel. So this brings us our entire conference and session to an end. I would hand over the stage to Dr. Mansuri.
Thank you so much, Dr. Patel. I think the best way to reach him is through the Research Update website. he doesn't respond to WhatsApp very quickly. So I think sending a
I
message.
try my best to I try my best to finish by the day end at least. Otherwise, all Sundays. Yeah.
Yeah, so that's one thing. But thank you so much, everyone, for attending on a Saturday. This was very last moment, but we thought we could just do it very quickly. We just advertised it like Friday night. So we started at about 120 people and we are down to 33. So these 33 are the true warriors who would go on to do some good research, it seems. So congratulations for staying till the very end. And we will be converting these videos hopefully quickly. Robin has them, so Robin should be able to get them out pretty soon, and it will be available on our website, Humans of US, on our YouTube channel, Humans of USMLE. And then yeah, I think next week we have a session for underrepresented in medicine folks, and we also might get some Caribbean graduates. So look out for some announcements on our end. Next weekend we'll again have lots of interview tips and tricks for all specialties. So we are still trying to get as many people as we can. So watch out for our announcements on Instagram, and we hope to see you next Saturday and Sunday. Thank you very much. Take
All
care.
the best, guys, and wish you very happy Diwali from our side. We'll see you soon in future.
Yes, happy
Bye.
Diwali. Thank
Have a
you.
good one. Bye.
Thank you, Dr. Patel. Happy Diwali.
Ending the session.
Happy
now.
Diwali, everyone.